Hi, this is Ryan Smith. I'll be presenting a case that kind of falls under the general medical case. Patient is a 71-year-old retired male, just evaluated a few days ago, referred for vertigo, disequilibrium, and there's a fall risk for gait training. Patient describes his primary complaint as the kind of dizziness feeling and then fatigue that goes with it that kind of prevents him from feeling like doing much of anything. He's had this for years basically at this point, but it's over the last couple years where it's gotten bad enough that he finally wanted to start seeking care and started getting some help with it. They started with just medications. As you can see, there's his photo results. So his primary complaint is just that dizziness and fatigue. He puts it as pretty much constant, little variable in that it's better in the morning, gets worse kind of throughout the day. He did say that it's not related to like a spinning, more of a lightheaded feeling that makes him that dizzy, and then the fatigue that kind of follows / goes with it seems to be at the same time. He puts them that they basically come on together. He never really had them this separated at all. So what could kind of lead to dizziness, fatigue? Just looking at joint type structure things, that makes me think possibly cervical, although I think it's low on the list. Definitely a neural possible component here. And then with the balance gait disturbance type things could also be due to kind of that lower extremity issues with coordination or weakness due to his lack of activity. And then dizziness issues with the vestibular system, maybe ocular, cochlear thrown in there, kind of that whole VOR system. So my primary hypothesis is kind of going on that vestibular type issues and probably looking at the neuro, and then still throwing in the lower extremity weakness, which I think could go with either one of those first two, and then possibly the ocular or cochlear to look at as we go. His aggravating factors, kind of like I talked about, is just that activity. It does get ease when he rests, lay down, sleep, or as he did start taking meclizine just for the dizziness, that does seem to kind of help, although it helped better at the beginning, not as much lately. He does, with the fatigue, just anything he kind of does seem to make that worse, and he didn't really put that it got much better, other than after sleep, kind of that same thing, first thing in the morning is probably best. 24-hour, no problem with sleeping at night, feels the best in the AM, but the rest of the day still just kind of feels that general dizziness, fatigue going on. He's had this for years, more that gradual increase over the last couple. He didn't put it to any kind of mechanism that he could recall, no falling, hitting his head, any kind of thing like that. He didn't relate it when he had his glasses re-prescribed this last year. He hasn't changed types of glasses or anything like that to lead to that ocular component. He does have prior history of cervical neuro, no prior history of the cervical neuro type issues, but he does take an antipsychotic, and then the meclizine is kind of the one thing tried. His red flags, he does have the fatigue that he describes, which would fall in that category. The weakness, which seems to be generally both sides, no kind of specific pathway there. He does have a gait disturbance, which kind of makes you towards that neuro. But those were kind of the reasons he was sent to PT, so they're already known. He does have a history of ulcers, a pulmonary embolism, and an MI in the 80s, and he currently has high blood pressure that kind of required a recent adjustment of medication to watch out for. So with those yellow flags, that antipsychotic I think falls in there for sure. And special questions, he hasn't really had any imaging testing anytime recently. He did have vestibular CT stuff, but as you see 15 years ago, that was normal. Medications, he has taken some things for cholesterol, the dizziness specifically, the heart disease, high blood pressure, and then he does have that antipsychotic there. And then when you kind of probed him, it didn't really come out till later, but he does drink rather regularly with alcohol as well. So my asterisks are still kind of going on just that self-reported frequency intensity for the dizziness and the fatigue here. So my primary kind of jumps more to that neuro, then maybe still the vestibular. Although I'm jumping with the alcohol use and the drugs that he's already taken with the antipsychotic and stuff, that it could be kind of induced that way as well. The parts I could probably rule out, I think, is more the ocular. Nothing really with vision. You didn't describe anything with like spinning, change of positions, movement. So the CENS I put as moderate just because he kind of feels it all day. It, you could almost go in the severe because it is limiting his function as he describes it and keeping him fairly sedentary. Irritability I put in that moderate in that it's just kind of there, but it's not really triggered much increase or decrease by any kind of triggers. And I asked some of those things with positional changes, with the alcohol intake, with when he takes his meds or not. But he's kind of on such a regular deal with taking those, it's hard to separate out. I would kind of put as my primary hypothesis is non-musculoskeletal at this point, and he is kind of in that chronic stage that's been happening over years, and it's gotten worse over the last couple. And the stability seems to be fairly stable and reproducible, but with that slight gradual worsening. To rule in, rule out, I definitely like to do a cranial nerve screen, still kind of looking at vestibular, VOR type complex. Manual muscle test of the lower extremity just to see that hasn't probably added into the fatigue and gait problems and things he's had. And then kind of a functional assessment with hand movements, with the walking, tug, that kind of thing. Well, I don't plan on deferring anything at this point unless you could really set him off, but time would be kind of more the reason I might miss or defer something here. Precautions, contraindications, he was sent kind of as a fall risk with the gait disturbance, so it's just something to keep in mind as he gets up, that you got to watch out for that. Just in his observation in the physical exam, he has kind of that slump seated forward, head, rounded shoulders. He does have that shuffling kind of gait, and when I had him up for balance testing, even in Romberg stance, he had problems. For the quick screens of joints and stuff, when I'm kind of doing legs, ankle, hip, those kinds of things, even the cervical movements with like the head thrust, having him do the vision, full range, like none of the movements with the neck, legs, anything kind of set off any dizziness problems with him. The neurologic exam with the cranial nerve, probably one of the bigger things jumped out is like a hearing, in that he was definitely decreased on the right, and he hadn't talked about doing an audio exam anytime soon. So maybe with the audio problems there could be playing into that system. And on the cranial nerve 3 with eye tracking, I guess /6 here, and 4, that he did kind of lack a little of that medial tracking with the convergence. So his eyes might play a little bit into this. We did talk about possibly, getting that checked out, but he recently had an eye exam last year. His manual muscle test was weak pretty much throughout the lower extremity. I'd put it generally around a 4 out of 5 on that. That there's definitely some strength gains to be made there to help him feel a little more confident. The functional testing, he did score 17 seconds on the tug, which most everything says anything around 13 to 14 puts you at a fall risk. So he's a fall risk according to the tug. And that poor balance, as I talked about with the Romberg. The special testing, though, with the vestibular, like the VOR, the head thrust, Dix Hall Pack, none of those came up as being an issue for him. He did other things to kind of mention here, though, as I was asking him to move and, do the manual muscle test, the sit to stand, any of those things. He did have difficulty starting and stopping with the motions. He was kind of slow to respond to commands. He lacked the fine motor control in that, the way he even wrote the intake form was kind of choppy. And he did present with some tremoring with intentions and then even a little resting. When asked to perform things that kind of else showed up with like checking his core, abdominal bracing, he had kind of a nauseated feeling being laid back. And with questioning on that, he kind of then talked about that he had that history of ulcers from the 90s and does get an occasional sharp pain in that lower left quadrant. So that was kind of a concern. I think unrelated to what I'm seeing him for, but maybe something to talk to him about / talk to his doctor about. And then in examining that a little further, palpation of the lower left quadrant abdomen, was painful for him. So that to me kind of says maybe an ulcer concern. So going through that, my hypothesis here with that shuffling kind of gait, the weakness, the hesitating on movements, the delayed reactions, those kind of things. I'm thinking more in that neural component with like Parkinson's. Uh, I think with that it could be medication slash alcohol induced, with that leads to some of that impaired function that could explain some of the dizziness symptoms as well. And then I think the lower extremity weakness is just kind of all part of that. When you've gotten where he doesn't want to do anything, it's kind of led to that through his inactivity, not necessarily a cause. And his historical exam now, what would I throw as asterisks? I still really only seem to get that self-report of him on, what's the dizziness fatigue like, what's the frequency, intensity. But now with kind of the physical exam, I can definitely look at, his manual muscle testing things, but I kind of like going on more of that comfort and his gait pattern ability, and then the tug is a nice objective measure we can look at as we progress here. Prognosis, if it is Parkinson's, he's undiagnosed at this point, that I wouldn't expect like a full recovery, even if it's kind of that medication induced. He's taking it as an antipsychotic. I doubt he's coming off that anytime soon. So I do think he can make, some more gains in his gait and that kind of thing, but I don't think he'll ever return to like a full level of function here. I do kind of put it as 6 to 8 weeks here on getting his confidence up, getting him the right things to do at home, and getting him kind of compliant there. Part of this is kind of going that we had a discussion about his alcohol intake and trying to get him to make some of those life changes that may be more challenging than average. I would like to see him a couple times a week to get him going on the kind of those sensory input things and that balance movement activity. Specific goals would be that gait increases probably within 6 weeks here, maybe 4. Where you're getting that tug less than 13 would be ideal, so he takes him out of that fall risk. If he's not making progress within like a couple weeks here, then I'd really go back to the doc to talk about, maybe that Parkinson's diagnosis or the medical management through changes in his medication slash maybe he needs treatment for the alcohol use. So my overall strategy is kind of that large movement training that goes with Parkinson's slash balanced sensory input stuff, and then the lower extremity general strengthening. Any questions at this point? One last thing to kind of say here, I did talk with his doctor. The doctor kind of put that the Parkinson's could be more related to the antipsychotic, so they kind of, the medication and the neuro kind of go right together, hand in hand in the doctor's mind. But that he leaves open the possibility that, even though it could be medication related, that does progress that now it is Parkinson's. So it does bring up the point for me, when do you talk with the patient that because of the medication he's taking is leading to these other deficits and things? And when do you talk about totally kind of treating, diagnosing as Parkinson's so that the patient becomes aware of that progression? Just a food for thought question I had. Thank you.